First, I want to start by thanking everybody for staying this Friday afternoon, and commenting that we've really had some terrific presentations. But the title of this day is Patient-Centered Diabetes Care. And we're still hearing very little about the actual role and involvement of the patient. So I'm going to think about that as we go through this presentation. I'm actually going to focus a lot on data. And I think as you look at this, these are averages. So, today of about 20% of care is actually in some sort of value-based contract, so whether it's a pay-for-performance or other risk-adjusted models, but we're heading towards 60%. And again, these are averages. You have some practices that are already at 100%. You have some that are a big goose egg. But this is going to force some very different conversations. The world will change in the next 5 years as we head towards accountable care organizations, et cetera. But for most practitioners, I think and office-based managers, the interesting question is, at what number do a lot of these changes make sense? It is really hard. Again, these are averages. If only 10% of my practice is some sort of value-based contract, I'm paid in a fee-for-service world, I'm going to have a fee-for-service mentality. So what's the number? What's the number that a practice needs to have in their practice to allow from a reasonableness, from a business process, for me to switch my practices? I have staff to pay. I have the lights to keep on. If I'm living in a 90% fee-for-service world, it is hard to make those changes. But we are going to see some pretty dramatic changes. And as we move from fee-for-service to fee-for-value, it really is to get to the triple aim. We must reduce costs in this country. We must improve care, and we must improve access. And we are not doing a great job. And as we start thinking about these conversations, there really are. They're the patients, they're the payers, and they're the providers, and probably in the order of patients, providers, and payers, And we each will need tools to manage this new world, but a big part of that is, again, going to be the patients. So we listed out here a number of tools that either the providers or the payers are interested in. And say you go first to a pay-for-performance in a fee-for-service market, you do need patient registries. Back when I graduated from medical school in the 91, the reality was I just took care of the person who showed up at the office or the visit. I did a really good job. I trained at CHOP, I knew what I was doing, and we delivered really good care. But it just wasn't in my realm to think about what happened when you walked out the door, And I ended up doing a lot of ER medicine, and, I was always curious what happened to you. Was that correct, the rash I called, or did the ringworm treatment work? But the reality was I did my job and I went on, and then, as you know, we got into pay-for-performance programs, and we started thinking, okay, isn't this interesting? I have this list of people who should be on my list and who aren't getting the care. I wonder where they are. It's curious. And the best thing I could do was put a little sticker on, and when they came in, I say, hey, don't forget your hemoglobin A1C today. Make sure you get that done. And then as you move up the risk value chain, you really do need additional tools. What I find is fascinating is we don't even, until we get to full-based contract, we think about mobile patient and mobile data that we can actually get from the patients. Now, can I use your phone? How many people have one of these right now? Let me ask it differently, because I think most people. Anybody not have a smartphone in this room? Okay, thank you. And isn't that interesting? So for the first time in history, we're actually there's a ton of both passive and non-passive data on those phones. That thing can actually tell you how much I've already walked today. Well, not her phone, but my phone. Her phone could tell you how much she walked. And so we're going to talk about that. But isn't it interesting? In all these years, we've sort of moved up the continuum, and we talk about patient-centered care. But it's really provider oriented around the patient, but it really doesn't actively involve the patient. It's still done to the patient. We talk about patient adherence or compliance, but at what point is the patient owning that care? When are you going to become, Amy, Dr. You? I'm going to argue you already are, but we're going to get there. That Amy's the best doctor for herself, and Danine's the best doctor for herself, and what tools, in addition to this, do I need, and what information can I give you back to help take care of me? Now, those tools are really important, and I'm going to get a little bit into, just very briefly, but we've spent a lot of time and energy on health information exchanges, and we're going to exchange data. I'm going to argue also that we have to make sure it's correct, and that it's important, and that it's not just analysis paralysis. You know how we used to do that in school? You know, it was just interesting. And look at all these charts I could produce. So what, right? So we have to make sure it's correct. And as you know, many of you know, we acquired an organization called Humedica a number of years ago, and that pulls, using natural language processing, et cetera. I'm going to switch this, and I'll go back to this. I didn't know whether I had to keep clicking it. That pulls clinical notes using natural language processing. It pulls information from the clinical notes, as well as the claims and the processing, et cetera. So we actually ran a study looking at 1,000 people using standard diabetes algorithms, say who has diabetes, et cetera. And then we actually added on the clinical notes, and we pulled that again. It lays on top of an EMR. And what's really interesting is that we found 22% more people who had diabetes and were not captured in standard algorithms using claims and RX. Isn't that scary? Here's what's really interesting about this group of people. They had 45% more admissions. They stayed 33% longer, 30% more ER. But here's where it gets really interesting. They had 73% less PCP visits. They had 66% lower 4 and 5 coded visits, 99214 and 99215, and 49% lower RVUs, 22%. Now, interesting, if these people would not be on your list, they're not be on your list for pay for performance, they're not on your list for Medicare stars, they're not on the list. And, you know, so isn't that interesting that I just want to caution everybody, we have to make sure that the data is not only, we spend a lot of, we're going to exchange this and this, but that it's analytically valid. And that's a tool, I think, as a payer, that we want to make sure that big data is really good data. And I think in the next couple of years, you're going to start hearing a lot more about good data. Because if you're the ACO or the bearer of risk, the real question I think you want to ask yourself is, I only do have so much time and energy, so what is the population that I really want to focus on? And somebody else already mentioned it. We want to prevent the clinical complications. We want to prevent the highest cost. And it's probably, from claims data, we can actually get the last two circles. But the reality is, from an NPV perspective, for you economists in the room, it's probably the second two groups. They're the groups we want to focus on. They're the group that intervention today will help you prevent a complication in the next 12 to 24 months. But good data can also be small data. And so, in this world of big data, which I'm sure most of you saw the New York Times article, and said, I think it was 9 reasons why big data is really hard. And I think it's because, and it was actually, I thought it was quite well done, as always. But, to me, the take-home message was there's always more to the story. And then, of course, the omics. I joke, but all the genomics and omics and proteomics and, how we're going to actually understand all that data. How many people in the room have been asked by a friend or family, should you do your DNA 23, what's that called, 23andMe? Anybody been asked by their friends and family? Yeah. It's an interesting question. I say, well, if you're interested in where you're from, that actually will answer it. But I think good data is also going to be small data. And we're spending a lot of time working with the folks, a woman named Deborah Estrin at Cornell Tech in New York City, that new campus that Bloomberg is building, to really understand the power of small data. And let me give you an example. I'm going to get to that. If I'm treating you for depression, and I can use, I can look at the trials, I can understand what's the best treatment for you, and I'm going to put you on Wellbutrin, and I'm going to say, okay, I'm going to see you in 2 months. Start at this dose. But wouldn't it be interesting? Can I use your phone again? Wouldn't it be interesting if every morning when you woke up, there's an app, I don't know if you've ever seen it. It's like a pain scale, only it's a happiness scale. And every day, when you just turned your phone on, you just clicked it. And on a scale of 1 to 10, how happy are you today? The real question is, how sad are you today? But we're going to ask it in a positive way. How happy are you today? And as a physician or as a caretaker, that's really important. And if you're like down in the dumps, number 9, for 5 days in a row, I probably should call you. And that's patient-delivered care data that are useful to me. But not only can it be useful to me, it can be useful to the patient. There's a, does anybody know the company called Hygiea? So, I don't know, do you know who I mean? Yeah, so Richard Bergenstahl, does everybody know Richard? Yeah, he turned me on to this company. And what they're doing, again, using data, big data down to small data to useful in the population. So I used my depression example. These folks, I think they're out of the University of Michigan, but they're doing all their trials so far in Europe, and they have the CE mark. But they use glucometer data, big data, and they actually profile it over time. And in real time, when I do my reading, it's not continuous glucose monitoring, it's actually just individual glucose data. It says to me in the morning, after I put my last reading in, it says, okay, today you're taking 40 units. Has anybody else ever seen that? Right. So the algorithms that some of these smart folks in this room spend their careers working on are built into the glucometer. So instead of going back to my depression example where I'm going to call you at day 5 based on your SAD, in the SAD, and say, hey, let's come on back in or let's up the dose. In this case, what it's saying is, okay, Deneen, the type 2 diabetic who's on insulin and checking my sugars, and I started you on, I'm going to make it up, I'm not a diabetologist, 20. Based on standard algorithms proved today, you've been running at 300 for 4 days. The machine uses standard accepted algorithms to say, give yourself 40 today. Isn't that interesting? So it is turning my real, based on population data, my real numbers in real time give me the data to allow me to make the decision. Does anybody think that's a bad idea? Is anybody else surprised? Do you? Yeah. The FDA, yes. And I agree. Like I said, this is done in Europe. But isn't it interesting? I do think, though, this new world we live in new data, we will see more and more, we will become more comfortable. There was a time, who remembers, probably before my time, to get a glucose reading, you had to go to the doctor, right? And at that time, nobody would have believed that you could do it at home. Nobody would believe that you could have your own care management and you could make some decisions on your own. So why can't we standardize this into an algorithm that it's, and of course it has to go through the trials, et cetera. But isn't that interesting that I can become Dr. Me with that kind of data? And the other, and this is my last slide, is getting to the issue of using big data to drive to an N of 1 in that, what works for me? We look at randomized controlled trials to understand what we should pay for and what works and what the FDA will approve and then what we should pay for. But then after that, there's always this question about, if I use as an example rheumatoid arthritis, it's always easier for me. There are a number of agents that you can start on. And how do you decide who gets on what and when and why? It's actually somewhat hit or miss. And so wouldn't it be interesting that using both, starting with obviously the randomized controlled trials and the data we have, but then driving to an N of 1 and saying, I'm going to figure out, Jeff, what works best for you. So I'm going to start you on agent X, and then every day you're going to check in. First of all, I'm going to say whether you went to work, are you walking? As you know, most people with RA are in their 40s, and a lot of them are still working. Are you going to work? Are you actually, how many steps you're walking? You were, and you might not even realize it. You'd say, well, I guess I'm the same, but isn't it interesting? You were walking 2,000 steps a day before we started this treatment, and you actually are walking 8,000 steps a day. You didn't even realize it, but I must be feeling better because I'm more agile. So, or that, you're still walking 2,000 steps a day, and instead of waiting for 4 months, let's switch you. You're getting no response. Let's just switch you based on your data and what I understand about the drugs, but giving it back to you and saying, let's move on. So I think, and in these new value-based world, we're going to see a lot of changes. You know, we're going to see patients become their own Dr. You. We're going to see, you know, physicians begin to make very different decisions because they're going to have the data to make so. They're going to figure out that, okay, I know those 22% of people I just identified for you were not on your list, but the reality is they're actually some of your sickest diabetics. And we're going to have to intervene. So that's it. Thank you. Oh, sorry. I added this at the end. Right. Thank you for adding this. This is one other example of, again, using, and many of you in the room may have been involved in this effort. So this is Richard Bergenstahl's slide that he let me use, and talking about how, you know, a lot of these glucose meter readings, you know, it's not like the EKG. Whether you buy an EKG from Philips or GE, the reading is standardized. And so we as physicians and you as patients, if you're reading your own, you know what it all means. It turns out in the glucose world, as you know, that's not the same. So there is this major effort, and we're very supportive of this, of standardizing output for glucose reading so that we can all get on the same page. But I also just love the ambulatory glucose profile from the perspective of, you know, I may have individual readings that this is sort of going reverse from N of 1 to the bigger picture, and I'm reacting in real time to this individual reading. But isn't it interesting that you could tell me, if you use smart algorithms and bring your own personal data together, your own big data together, and say, isn't that interesting? Every night at 7 o'clock, I spike. So my hemoglobin A1C would say, well, I'm still running at 8.5 or 9. I have to change the med. But with this level of data and specificity and presentation, I can say, now wait a minute. I know my hemoglobin A1C is 8.5, but wow, I'm actually great until every day at 7 o'clock. What do I do at 6 o'clock? Well, it turns out I stop at Rita's Water Ice every day, and I wasn't going to say that. I picked Rita's Water Ice. That seemed more clean. She was joking. She's showing a glass of wine. So Rita's Water Ice. So I have to make a choice. I don't necessarily need a new regimen. I have to decide. I either do something at 6 o'clock, right, or I dial down the Rita's Water Ice, but it's not a wholesale change, you know. So again, a great example, and we're working with Richard on a number of these projects to begin to turn big data into good data. Thank you.